introduce you, Jonathan, if that's okay. Jonathan Leach OBE, who is the NHS England Medical Director for Covid Immunisations. And sorry.
No, so I'm Jonathan Leach. I'm a general practitioner here in Worcestershire, so I see my own patients and have been vaccinating in care homes, in mass vaccination sites, and I was doing this on Saturday. And then I'm also, because of a sort of long history of doing mass vaccination in the past, the medical director for Covid vaccination for England. So it's a huge privilege to be doing this, and obviously hopefully making a significant difference, you know, to my patients, to the NHS and to the country. So it's brilliant. Would you like me just to do a sort of quick sort of update where we are, Jonathan?
Please, John, well, from one Jonathan to another, please do.
Always best, always best, always
and please, we spell it the same as well.
We do, so that's even better. So so let's just give you an update. And obviously there's quite a lot in the press, so I won't cover some of that, but essentially the country's doing well, and I'm conscious we've got colleagues from the Israeli embassy, and obviously that this is a huge international sort of effort, because essentially the world, as you know, is in the same place. So the concerns are obviously not just regarding the coronavirus, which we've got at the moment, but also some of the emerging strains, which are obviously found initially in this country, and then some of the ones from South America and elsewhere, South Africa as well. So in the UK, and it is amazing, absolutely amazing, that in just over a year, we've gone from the discovery of a vaccine of a disease to actually having a vaccine. But I've been involved with many of the discussions, and actually I'm very comfortable that no short circuits have been taken. And actually what's different is that normally we would do all of these things in sequence. You know, you should develop, you know, so the difference is that this has been done in parallel. So I'm quite comfortable about what we call the pharmacovigilance elements of this in terms of the safety. So we've got two vaccines. There's one obviously by the Pfizer one, which we've been using in the UK since early December. And we've then got the AstraZeneca one, which was authorised at the beginning of the year. So for the UK, actually we're doing well. We're out to today's data, we've now had 6.4 million people vaccinated in England. It'll be more across UK. I don't have the data from Scotland, Northern Ireland and Wales. And actually, given the fact that we know that age is the biggest risk factor, we're now over 80% of our care homes being vaccinated, and over 80% of residents in care homes. And actually, given the fact that we were using particularly the Pfizer vaccine at the beginning, which is the one with this very tight and difficult cold chain, actually that's an enormous achievement. There's no question of that. So actually it's going well, and the three main delivery models for across the country are through hospitals, and 214 hospital hubs, that's what I've got in my data, through the mass vaccination sites that will have 49 shortly, and then over 1,000 GP practices. So where I am here in Worcestershire, all the practices have joined together, and we've been doing that. So, you know,
Jonathan, I'm going to interrupt you and give a plug for my own wife's GP practice, because if you saw the BBC Panorama programme with the outdoor tent constructed, that was my wife's GP practice just half a mile from here in Temple Fort.
Brilliant. And actually, I think having done lots of vaccinating, and my two comments would be that firstly, the staff have been amazing. They've really pulled, but also patients have been gracious and grateful. And whether or not that's, you know, I was vaccinating members of health and social care professionals week last Sunday, doctors, nurses, social workers, social staff. Actually, probably the most important person I vaccinated was the lead receptionist for our local emergency department. She was really important, actually. I was really pleased to see her, as well as consultant physicians and other doctors. And then in care homes, and I put a thing on Twitter, and again, this is what's probably the most important thing to me as a doctor. I said, look, you know, I just vaccinated 50 or 60, and it was a daughter who came after me and said, Dr. Leach, thank you very much. One of those was my mother. And actually, this is, to me, you know, that probably is the most important thing, rather than, you know, it was that personal side. So anyway, that's where we are. There's clearly debate regarding the presence or where the second dose should go. That is playing out. Certainly, when I've looked at this with, sort of colleagues from the Joint Committee of Vaccine Immunisation. I'm not on that committee, but I've spoken to quite a lot of them. Their view is the balance is this: that in a perfect world where we had enough vaccine and we had everything stood up, you would give the second vaccine at 3 to 4 weeks, and that's clear. But given where we are with regard to increasing numbers and deaths, it is better to vaccinate more people in a shorter period rather than give a fewer people in a shorter time. Now, that second vaccine, I've got nothing to think that the second vaccine won't be delivered. We've got enough supply. And actually, that second vaccine is really important because of the fact that it's important to boost immunity, but also we think it will give a longer immunity, which is also the important thing. And actually, there is a debate, but the immunologists think coming slightly later might be more effective. So essentially, that's the UK policy. I appreciate there's a debate and that academic debate's continuing, but that's where we are.
Again, I'm going to tell my colleagues, Jonathan, if I could interrupt for a minute, but I've got a few questions already been sent through during the day, which I'll come to in a minute. But if anybody's got any questions they wish to ask, either email them or actually easiest to post them in the chat.
Yeah, that's fine. I'm happy to do that. I can't see the chat, so
I'll give them to you, don't worry.
Oh yeah, 20 questions.
I mean, the first question I've been asked actually to ask you was, if you were given the choice of vaccine, what would you choose to have?
To be honest, it doesn't really matter. They're both effective vaccines. As a healthcare worker, but it was only the one that was available. I had the Pfizer, but if it had been the AstraZeneca, I wouldn't have minded. They're different vaccines. They're manufactured differently, but it doesn't really matter. Both are effective, and especially in the context of other vaccines that we have, maybe around tuberculosis, which is lower. So they're both effective, and certainly we're hoping that we will see a drop shortly in particularly these elderly patients who unfortunately are admitted to hospital. And this is one of the key things. So it actually takes that pressure off the hospitals. But it may take longer because obviously a lot of the people in the hospitals at the moment are the younger group. And of course, we haven't yet got to vaccine. But we will be, the plan is very much that by the middle of February, and we've got every intention of meeting this, we will have reached middle of February, the government target, that we will have vaccinated those in cohort 4, which are the shielding group, and those aged over 70.
So one of the questions asked was about you mentioned this about the two vaccines. Obviously, there's a third one globally, which is the Moderna one, which is I think also been acquired by the government, but I'm not sure if it's arrived yet. So the question is about the adequacy of supply of vaccines. Are we comfortable?
Yeah, so I've seen various things, but actually I was talking to the senior reporting officer who looks at all the, this is a lady called Emily Lawson, who's the senior reporting officer for NHS England. And actually we think we have. Clearly we're monitoring that and we're making sure that it goes to the right place. But as I sit here today, then we're as confident as we can be, but clearly there are lots of political things swirling around at the moment. But as we sit here today, we're as confident as we can be that A, we have the vaccine, and secondly, we have the delivery mechanisms to do it.
And how do you ensure, because obviously you hear stories about supply here and not supply there. How do you ensure that there's a consistent source of supply around both London and the rest of the country?
So actually one of the questions has been, so, for example, where I am in Worcestershire, actually we've done very well, so I think we're the third highest in the country. So one of the questions is making sure that the supply is delivered equitably. So particularly to make sure that, it may be in areas where the GP practices haven't perhaps been as organised, and making sure that the needs of the population. So one of our responsibilities is making sure that that is distributed properly and equitably and against need. So, and that has caused some conversations in the press about GPs saying, look, why can't I get more vaccine? I want to push on. I get that, but also we have a responsibility within the supply to make sure that it's delivered equitably in order to make sure that that's across the population.
And in terms of people refusing the vaccine, what type of refusal rates have you seen around the population, and what more can people like us do to convince people to take the vaccine?
So this is an interesting question. For the elderly group, who clearly at higher risk, actually we haven't had that, or certainly, you know, very, very few. And actually the do not attend rate, the DNA rate for a vaccine has been virtually zero, literally, you know. And actually it's, you know, we had somewhere somebody turned up 4 hours early because they didn't want to miss their appointment, and actually turning up early is a problem. So don't turn up early, turn up on time. So, or at least only 5 minutes before. I think as we get into other cohorts, I think this will become more of an issue. There certainly have been some conversations, and we've been conscious of social media, where some social media leaders have been giving misinformation. So I think there's certainly something, and I was talking to some of the charities last week, that actually where you and others could help with is helping regarding the information about the vaccine, helping people understand about it, and also where perhaps somebody might be very vulnerable, assisting in terms of maybe them accessing the booking, and actually assisting in terms of maybe even going to their GP surgery or the mass vaccination centre or wherever it is. So actually that would be one of our particular asks, particularly for your community, that it's really important that we get this equitable access right across.
Because there have been anecdotal stories of spaces in the mass vaccination centres and not enough at GP surgeries. Is that more anecdotal than real, you think?
Yeah, it's more anecdotal, you know. It's, you know, so what we do is that so that some of this has been down to booking. So the mass vaccination centres have used, particularly post, GPs have been ringing. And actually we've been doing it like we would do flu, actually. So I think that there's something about that, that you know, we need to support the population for both individual levels and population health to access the vaccination, and obviously deal with any queries and concerns that they may have.
And what is the current view in terms of the longevity of the vaccine, in terms of whether or not you will need to have a renewal process at some point in time?
Actually, good question. Well, good question. We don't know is the short answer. So it's what we call an inactive vaccine. So it doesn't have live virus in it. So in this respect, it's the same as the flu jab that's given to adults. It's different from the childhood one. So, you know, if I was to polish my rather murky crystal ball, and it is fairly murky, I wouldn't be surprised if, you know, in a couple of years' time, you know, it might be delivered alongside flu or something like that. But essentially, you know, you know, I think that's further work to take place. And Public Health England and right across the world, obviously this research is going on regarding the longevity and the degree of immunity that we have. And obviously it's in the context of the mutating virus, which is obviously a concern to all of us.
So there's 2 questions I'm going to put together, one from Keith Black and one from Luciana Berger, which relates to people on the front line having vaccinations. And Keith's question is more focused on school teachers, whether or not for post-February, you know, school teachers should be prioritised. And Luciana talks about the fact that there are 9 priority groups receiving the vaccination. And do you have a view whether people doing critical jobs, frontline or otherwise, should also be prioritised? Which I suppose merges into the same question.
Okay, so let's look at occupation. And actually, I can point you to an Office of National Statistics paper, which actually looked at the first wave. That looked, it only was published yesterday, that looked at the occupational groups and which groups were at highest risk. Okay, it is unfortunately often things like care workers, taxi drivers, bus drivers, people like that. I can send that to you. It's in the public domain, and it gives a lot of interesting, although very sad and sobering reading actually as to who has been, you know, affected. So the strategy in terms of occupation is clearly care home workers. They're in priority group 1. And as Luciana says, there are 9 groups. And then it's health and social care professionals. Now that healthcare workers, so obviously if you're a paramedic, a nurse, a doctor, that's included. The social care is quite broad.
2 hours.
So, for example, is that I did also, for example, speak with colleagues who were funeral directors last week, because actually they're important. I hate to say it, but they're an important group. Or the manager of our homeless hostel. So actually that cohort is quite broad if you are in a health and social care professional. We've given information to the NHS to make sure that they are given vaccination as part of cohort 2. Now, other groups, care workers, if it is your job, then you are also in cohort 2. So if you're going from one place to another, if you're an informal group, and we could have a debate, you're in cohort 6. So if it's somebody going to see normally their own individual family member. And the difference is often if you're somebody who works for a care company, you're going from one location to the next, you're going from one client to the next to the next. So the cross-infection reasons are different. Now, there is a comment in some of the JCVI minutes that other occupational groups like the police, teachers, my former colleagues in the military, the government may wish to take a priority group because of the importance of them as key workers. Now that may be where we end up, but that's not where we are yet. JCVI has done it on the basis of saving lives. Now that's more a political and an economic argument rather than anything else. So that's not really for us as the NHS, but clearly we would respond to that as you would expect if we were asked to do that. How, you know, but I think that's it. But it is in the minutes of the JCVI that may be a position that the government may wish to take, but that's not for us at the moment, if that answers that question.
Yeah, another question. Will there become a stage where the UK population gains herd immunity? And if so, what percentage of the population do you think will need to have been vaccinated for that to have reached?
Interesting question. The problem with this, of course, is that we've got differing, well, firstly, we don't know the level of immunity and the length of immunity from the vaccination. That's the first thing. The second thing is obviously we've got these new strains. So, you know, we have to vaccinate against flu every year because you get what's called a genetic drift. So if you like, the genetic code drifts from one year to the next. Actually, where we get things like Spanish flu, we always use countries, don't we? The variant will always be known as UK COVID. I'm sure it will anyway. But you know, it's where you get the shift, and it's a major shift that actually where we often get the flu pandemics. So I don't think I can answer that question because I don't know. Nobody really knows. But it's certainly clear that we need to get a degree of immunity. And actually where we are at the moment, the strategy is to protect the most vulnerable, to allow children to go to school, parents to go to work, and the economy to open up.
I guess that what you just said begs a question, which is, as a non-scientist, I'm going to ask this for you to tell me as a scientist it's not possible, which is that do you see a merging of the yearly flu vaccine and the COVID vaccine?
I wouldn't be surprised. I wouldn't be surprised. And in fact, I was talking to some of the cancer groups. So we know that, for example, having major surgery, not just chemotherapy, really affects your immune system. So there was a change last week in the Green Book, which is the main reference text, the immunisation against infectious diseases. There was a change last week, which we were supporting, which was that if somebody was going to be having chemotherapy, let's say somebody had a testicular cancer or a lady had breast cancer, that they could have their immune system's normal, okay, at that stage, okay, if it hasn't spread, that they would have vaccination prior to starting treatment. So actually you get that best response. There's a similar argument that what I expect that actually before, let's say somebody was going to have major surgery, just as, for example, you might have your pre-anesthetic check, we need to get to a place that as part of your pre-anesthetic check, this is just part of normal. You know, so you have your blood test to test you're anemic, and if you've not had your COVID vaccine, you have that as well. So that actually you're protected, because also major surgery is a major impact upon your immune system. So if you like, it becomes a normal part of clinical care, but we're not there yet. But everybody, when I've said that, to do that obviously makes an enormous amount of sense. It just needs to become part and parcel of normal life, and we manage it in order to be able to get the best effect from the NHS.
I'm going to merge two questions that I've got on my chat for your final question, Jonathan. Then I'm going to really be thank you and release you. First comes from Bernie Yaffe, who actually is the head of in Manchester, a large care home organisation that we have in Manchester called the Federation, and from Laura Marks, who runs Mitzvah Day, a very well-known charity within our community, which goes out and does good deeds to the outside world and within our own community. Bernie says he's delighted that 100% of the Heathland residents, which is the care home, have been vaccinated. And the issue has been convincing all the frontline nursing staff, currently 80%, who are many are overseas workers, who have cultural nervousness about having a vaccine. And Laura asks the same question in reverse, which says that we know that BAME groups or BAME groups are most reluctant to have the vaccine, and we know they're fed misinformation. And whilst the Jewish community is only sort of in that community, there's reason to believe that parts of our community are also resistant. What would you say to those who are resistant to the vaccine? And what can we all do within our own organisations to reassure them and ensure that the vaccine is spread as widely as possible?
So I think it's a very fair question. So, again, as I said at the beginning, I've got no reason to think, although it was a shortened time frame for the Western world, none of the regulatory things were shortcutted. I'm not sure that's the right word, but you know what I mean. The normal procedures that we would follow were followed. What happened, of course, is everything was done in parallel. And what was different was also, rather than, for example, AstraZeneca and the Oxford group sending this enormous great dossier to MHRA at the end, they gave them that information as they were going. That MHRA is the Medicine Healthcare Regulation Agency. So if you like, we were able to concertina that. I think there's that bit. I think that there's then something about they need to be really having that conversation. So if I give you an example of a nurse I vaccinated, she was, this was last Sunday. She was a nurse. She wondered if she might be pregnant. She wasn't sure. And she was working on the surgical ward locally, which isn't a surgical ward, it's a COVID ward. And we had this sort of very good conversation about the risks and benefits. It was a very open conversation. And I said, to the best of our knowledge, we've got we were using the Pfizer vaccine at that stage, but it was the same for the AstraZeneca. To the best of our knowledge, we got no reason to think that it would affect fertility or be causing harm to her unborn child. On the other side, she was an older nurse, and if she became unwell, firstly, she wouldn't want that because she was a very professional nurse and wanted to go and do what her professional job is. But secondly, actually being very unwell in itself obviously can have an effect upon the individual and the unborn child. So there's a balance. And actually, I think the thing to do is actually give information, dispel the myths. I certainly don't feel I'm being monitored by Bill Gates because of having had the Pfizer vaccine. I've probably got enough iPhones.
I'd quite like to be monitored by him if I could learn.
Yeah, actually, I think it's Tim Cook because I'm using an Apple computer. So actually, I think it'd be much more likely to be Apple. But I think that providing accurate information in a way which is culturally sensitive, in a way that's helpful, I think is right. Now, some of that might be for maybe those with learning disabilities, and actually putting it in, in a way that they can understand. And obviously at a tempo that people understand. It's not just the information, it's the tempo. So I think where you could be particularly helpful, as I say, is helping us to provide information, dispel myths, and also to assist people as they wish in terms of gaining that, what we would describe as informed consent. We're not here to do this to people. There are a few people where it is in their best interest. So in the care homes, there were, I think, 4. There were conversations with the care home because they didn't have any relatives and things like this. And just for care homes, just to put this in context, it's probably the most effective thing I will ever do in my professional career, because the data is for that group. If I give 20 vaccines, I save a life. It's probably the most effective thing I will ever do in my professional career. So, I think where you could help us, yeah, and it's really powerful. And then for us as health and social care professionals, it's clearly important for us, so that we can continue to do what I describe as our job and, you know, our role.
Well, look, Jonathan, can I thank you on two counts? Firstly, to giving up your valuable time today. I'm sure that, like myself, all my colleagues have found it hugely valuable to hear from you. And secondly, to thank you and your colleagues for the extraordinary work that you're doing in rolling out this vaccine around the country. I think everybody's watching, you know, with admiration the way that the numbers are totting up around the country. And as I said, I've seen it with my own eyes, the way in which people have been so extremely grateful. And I also know, and I think it's something that's somewhat underrated, the amount of effort that the doctors and nurses and all the healthcare staff around the country have put in to ensure that this is being rolled out as soon as possible. So I think on behalf of everybody, thank you for your time. And if you can pass on our thanks to your colleagues and all the staff, then we would appreciate if you could do that.
Yeah, and thank you very much. And as I say, I'm very happy, you know, you'll get my style. I'm very straightforward. You know, if I don't know the answer,
it comes with the name.
Jonathan, absolutely. So, but no, I'm very happy to come back, and I do see this as part of my role as the medical director, actually. So if I can be a further assistance, then I'm happy to do so, because I think it is an important thing that people have the correct information in order for people to make a choice about accessing the vaccination. And I think that's it. And so I'll stop there. But thank you very much for your best wishes. I will pass those on to the team, and obviously to my clinical staff, and just give you a sense. So as I said, my surgery's priority this week is to vaccinate the 80 housebound who we haven't been able to get to, and the remaining people in our care homes who we weren't able to get to because either they went there or they were unwell, for example, in a hospital. So it's been and continues to be an enormous effort by everybody, and I think we're all committed to do that for the obvious reasons. But thank you very much. I wish you all well, and thank you very much for inviting me.
Thank you, Jonathan.